So maybe I will just start presenting our organization. We are an organization called STARS. STARS stands for Sub-Saharan Africa Consortium for the Advancement of Innovative Research and Care in Sepsis. So we are a big project. We have eight partner countries in Africa, and we work with the Charité and Düsseldorf in Berlin and Düsseldorf in Germany, the two university hospital. And we are a foundation who makes a lot of research in sepsis care, especially in telemedicine. And so we are now a great family, and we introduced now this webinar, this lecture series for the one who do not know us. To give the chance to everyone to have more knowledge about sepsis, which is a disease that is quite hard to recognize and kills millions of people all around the world every year. So this is now our eighth session of the Global Sepsis Lecture, and the topic of today will be early detection of sepsis from a nurse's perspective. I'm really happy to have two great panelists. Our two panelists are, first of all, Kathleen Fallman. Kathleen is a critical care nurse and specialist from the US. She's a consultant and educator. She has published a lot of guidelines and papers around sepsis, critical care, RDS, and so on. She, as I said, took part of the development of a lot of international national guidelines, and she's also the president of the World Federation of Critical Care Nurses. So thank you so much for being here, Caitlin.
Thanks.
And I will also present Emmanuel. Emmanuel Champong is an emergency nurse from Konfo Teaching Hospital in Kumasi in Ghana. Emmanuel is also the national coordinator of the Advanced Trauma Life Support in Ghana and is the nurse lead of the AFEM. The AFEM stands for African Federation of Emergency Medicine. So thank you so much for being here, Emmanuel. This lecture, you will have this lecture can be recorded, and it will be downloaded on our website if the panelists agree. And you also have the material. Perfect. You will also have the material of the other lecture on our website, and a lot of literature and material. So just go on our website. It's free, and you can, I think, learn a lot. So thank you so much. I won't talk further and let the panelists talk. Thank you so much for being here, and have a good lecture.
Thank you for having us. And I'm going to start off um, talking about the early detection of sepsis from a nursing perspective. And what I'm going to cover in the time I have with you is sort of I'm a firm believer that if you understand physiologically what is happening in the body, the signs and symptoms that the patient presents to you will make sense. And you'll begin to have a better idea of recognizing that patient that is getting into trouble. And Emmanuel's then going to talk about some of the structured screening processes and the pros and cons of those various tools for us to introduce into our clinical area to be able to recognize. Because here's the thing, if you don't recognize early, you can't treat early, and the patient ends up dying. And so that's why we have such a significant problem around the world related to sepsis. So I'm putting these disclosures forth. I am not sponsored by anybody to speak for this presentation, but in the past I've been sponsored by these companies, and Emmanuel has no conflicts of interest. I'm teaching, so you're going to get learning objectives. So, as I shared with you, I'm going to explore the physiologic derangements associated with sepsis and then be able to connect them to the signs and symptoms that you see um, that the patient displays. And I'm also going to be using the chat box. So, get your chat box ready because I've got some questions I'm going to put out to you as we go through this. And then Emmanuel is going to talk about the strategies and tools that can help the nurse with early detection of the septic patient. I think it's important just to have a overall foundation of the significance of the challenge of sepsis. It is in the third iteration of the definition, and I've been around for all three of the iterations of the definition. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host in response to infection. Now, if that's all we had was that definition, that would be really difficult to pick that patient out in the clinical arena. That's why we're going to delve into it. Sepsis affects more than 49 million people annually, causing about 1.1 million deaths globally. And that data comes from the WHO. In resource limited settings, they face challenges such as lack of diagnostics, delay in treatment. Some of that can come from lack of early recognition and then limited ICU facilities. But again, if we can find these patients early in the med surg environment, or in the emergency room, that we can start those therapies and prevent multi-organ dysfunction. And early, as I'm stressing, and that's why we're having this webinar, early recognition is absolutely critical to ensure that we are able to launch those effective treatments, which are simple antibiotic and fluids for improved survival rates in this journey. But think about this, 1 in every 5 deaths worldwide is related to sepsis. That's huge. So, how do I, as a clinician, recognize a life threatening organ dysfunction caused by a dysregulated host response to infection in my patients? So, we're going to break this down. So, understanding the physiology of the disease, you have the invasion, and the invasion can occur from a bacterial infection. You can also have translocation of bacteria from the gut. You can also have a virus that ignites this process or a fungal infection that ignites it. And that launches this pathologic immune response. So it launches the immune response, it gets overwhelmed, and it becomes a pathologic response. And that's what we end up seeing. So I have a knowledge question. All right, everybody get your chat box ready. Why is it so difficult to recognize our patient? So I want you to put the letter in the chat box that you think is the answer to this question. Sepsis always presents with a high fever and obvious infection signs. The earlier symptoms of sepsis are often nonspecific and can mimic other conditions. Sepsis only occurs in patients with severe trauma. Oh, look at all you guys already putting the right answer. And most patients with sepsis don't show any changes in their vital signs. So you guys got it right. Yay. The answer is B, and it can often mimic other conditions. So it is hard to pluck out that this is the patient that has sepsis and this is what I need to move on as a part of it. So thank you everybody for answering that question. I know this is an extremely busy slide, but I'm actually going to break it down, not on this slide, but in subsequent slides, what actually happens. So you have this infection, bacterial, fungal, virus, that launches the immune system. So you have activation of the white cell, the WBC. And then what happens is it has a massive cytokine, so mediators, they're called mediators, release that creates a whole host of dysfunction in various uh, systemic systems, your vasculature, as well as what's happening in your cellular, and then it leads to hemodynamic compromise. But This is a busy slide, but I'm going to break it down to you. Basically, what this is we lose our balance in homeostasis. So normally there's this lovely little balance that we have when something invades us of we have just enough coagulation, just enough inflammation, and just enough busting of the clot that everything stays in balance. But what happens in sepsis is a complete imbalance. We have a pathologic level of coagulation, a pathologic level of inflammation, and then a reduction in our ability to bust up those clots. So just think about that. Think about the microvasculature and what that would cause by having overwhelming coagulation, overwhelming inflammation, and then the inability to bust up those clots. So this is what happens. Maldistribution of blood flow. Makes total sense. If I if my vasculature is full of clots and I can't bust them up, I've got mechanical obstruction taking place. Tiny little microemboli through the vasculature. The other thing that happens with our blood flow, because of the different inflammatory mediators that are released, we have constriction and dilatation happening irregularly, not in a kind of symphony where body signals are telling us we should constrict over here or dilate over here. I like to call it, it's sort of crazy in the vasculature. And then the vasculature has regulatory properties. So it starts to leak because the vasculature endothelium begins to break. And that's why we get the third spacing and the edema that we end up seeing. And the endothelium does a lot of regulatory activity on coagulation and something called reactive hyperemia. I am going to ask you guys a question. I want to know how many of you tied a string around your finger as a kid and had trouble getting it off? Anybody do that? All right. How many little kids? Okay. Thank you. Thank you. And then you cut it, and what happened? You had ba boom, ba boom, ba boom, and it turned all red. That's reactive hyperemia. Your body says you shorted me oxygen while you tied that string around the finger, and now it's off. I want 5 times more coming to me so I can rebalance things. That's lost as a result of the damage of the endothelium. So all of that leads to a significant imbalance of oxygen supply and demand. The demand is very high because of the sepsis, the infection, and the body trying to fight it, but the supply is having challenges getting there because of what's happening with the vasculature. So we don't have enough supply to meet the demand. And when you don't have that, you have something called oxygen debt. In other words, the cell doesn't have enough oxygen. And I'm taking you way back, everybody, to school to be able to make energy in the cell. And when we can't make energy in the cell, we flip over to a non-oxygen process, and that's anaerobic metabolism. And if any of you are familiar, if you remember this, there is a byproduct of anaerobic metabolism that we measure as a lab. Anybody remember what that is? It's lactic acid. That's the byproduct of anaerobic metabolism. So when your lactate is going up, it basically means your cells don't have enough oxygen to do the aerobic metabolism, so it has to switch over. And that's when our cells get in trouble and the organs get in trouble and they start to fail. The third pathophysiologic characteristic is metabolic alterations and activation of our sympathetic nervous system. Our body is in a fight or flight reaction. It's saying, okay, full court press. I need to make more glucose. I need to rev up, increase my heart rate, try and squeeze my vasculature, try and do all of this stuff to save and make sure I get enough oxygen to the tissue. And we end up, as part of that, with insulin resistance. So, how many of you in these patients have seen signs and symptoms of hyperglycemia? Because that's actually one of the signs and symptoms is hyperglycemia. And that happens because the insulin's not taking the sugar into the cell. So we raise up our sugar in our vasculature. So you're going to be able to see how we end up getting these signs and symptoms. So I have another knowledge check question. Why do we see maldistribution of blood flow in sepsis? And I want you to select all that apply. Is it because there's widespread vasodilatation due to these inflammatory mediators, increased capillary permeability, the leakage of the vessel? Our blood flow is not working in the microcirculation. Is it decreased metabolic demand in the tissue during sepsis? Or do we have formation of microthrombi obstructing capillaries? It may be easier to put which one isn't maldistribution of blood flow in sepsis. Which letter? I'm going to wait a few minutes, let you guys read this. So the answer is D is not,
Mhm.
because we do have huge metabolic demand in the tissue during sepsis. So well done, everybody. That's awesome. So these are the signs and symptoms that we see. But I don't want you to get overwhelmed here. We're going to break these down. Chills make sense because of the fever. Alteration in LOC, so basically alteration in mental status, is a big one that happens in our med-surg environments. It happens and it's recognized in the emergency room when the family may say mom's not making sense or dad's not making sense. But the two things out of this list that I want you to remember is unexplained tachypnea and unexplained hypotension are medical emergencies. And by the way, those only take a blood pressure cuff and your observation. So they're not resource heavy to be able to evaluate. So what do I mean by unexplained tachypnea and unexplained hypotension? We take care of patients that have COPD that may be breathing 30 a minute as their baseline. That's explained tachypnea. But if somebody is not have pre-existing lung condition and they start to breathe rapidly, that becomes a medical emergency. Why? Because the body is trying to blow off acid, whether the acid is caused from the lactic acid or it's caused from some type of other metabolic acidosis. It's an emergency. So if I all of a sudden have somebody that was breathing 16 and they're now breathing 28 or 32, and those are deep breaths, and I can't explain why it's happening, that's a patient I want to signal I need help. Same with unexplained hypotension. If I have not given a sedative medication or a antihypertensive medication, and all of a sudden my blood pressure drops, that usually is a significant sign. Oftentimes, what we do in the clinical area when that happens is we call our physician colleague and they may give us a fluid bolus to raise the blood pressure just enough that for another 2 hours until it drops again. And that can go on for 12 to 24 hours, and then the patient crashes. If we address it right when that is happening and look for other signs and symptoms of sepsis, we are going to catch that patient early. So if you don't remember anything else I say, remember unexplained tachypnea and unexplained hypotension are medical emergencies. We talked about why the heart rate increases. That's trying to get more oxygen to the tissue. The platelets go down because of that hypercoagulation. We have changes in our skin perfusion. I'm going to talk about that. And then our urine output goes down. May I ask the group, how many of you are using weight-based urine output or still evaluating efficiency of urine output by 30 mLs per kilogram or 30 cc's an hour? Because way back then I learned, oh, if they don't pee 30 cc's an hour, then there's something wrong with the kidneys. And the science has told us we now have to ensure that we're weight basing our urine. So that's why it's 0.5 ml per kilogram per hour. So at the beginning of your shift, you should be figuring out how much urine, either per hour or every 4 hours, that they should be making. Because that's a sign that the kidneys are getting in trouble, and that's usually one of the first organs that gets hit. The hyperglycemia I talked to you about, purpura and petechiae, those are those little bleeding under the skin. That's not a good sign. And then if you have challenges with getting lactate, one of the things you can evaluate is skin modeling. And this has actually been looked at in being able to determine mortality rate and used in low resource settings. So if you look, now this is somebody whose entire leg is modeled. They're not likely going to survive. It's a high sign of mortality when the entire leg is engaged. What I usually see is initially, so that's why it's important to pull that sheet back, is the doctor I worked with that I did my initial training in the environment, he called it the knee sign, where you started to get modeling in the knee. That's a score 1. Score 2 is when the entire knee is engaged. So you can see that in your slide right here. And then this is a score 4, which is the entire leg, and that is associated with very significant mortality. So this is something, again, that doesn't require significant resources to be able to assess and know your patient is in significant trouble. And we've got to do something. So when there, another knowledge check, so get your chat box ready. When there is no medication or chronic disease related reason for the abnormal changes, what 2 clinical signs that we regularly assess should be considered a medical emergency? Hyperglycemia and normal oxygen oh, look at all of you guys. Hypotension and tachycardia, mild fever and slightly elevated white count, or hypertension and a normal respiratory rate. Well done. Awesome. And now I'm going to hand it over to Emmanuel so that he can talk about some of the signs and symptoms of how we put it together as a clinician at the bedside to be able to make it easier for us to do the right thing.
Thank you very much, Kathleen, for your wonderful presentation. I will continue from here, and here we'll be talking about what key signs should hospital staff watch for or need to look out to recognize sepsis early. Now, key early signs of sepsis include altered mental status, abnormal respiratory rate, hypotension, elevated lactate more than 2 millimole per liter, and other physiologic changes that is detected via vital signs or early warning scores. Now, these indicators guide prompt assessment and timely intervention. Next. So, tools used in screening for sepsis. There are several tools that can be used in the screening for sepsis. Now, each with different strengths, limitations, and applicability depending on the clinical setting. So, based on the implementation guide, the primary screening tools may include using the SIRS criteria, which is the systemic inflammatory response syndrome. Here, we'll be looking at the temperature. So, a temperature of more than 38 degrees Celsius or less than 36 degrees Celsius is one of the criteria to look at. And then a heart rate of more than 90 beats per minute, and a respiratory rate of 20 beats or 20 breaths per minute. We also have to look at the white counts as well. Now, we need to understand what we need to understand is that if we're using the SIRS criteria, there's a high sensitivity but low specificity, leading to many false positives. So and this may be familiar to many providers, but may generate false alarms if used alone. So you may need other parameters to also add to be able to make an informed decision. We look at QSOFA as well, the quick sequential organ failure assessment. This one incorporates three criteria. So altered mental status, as mentioned earlier, systolic blood pressure of equal to or less than 100 millimeters per mercury, and a respiratory rate of more than or equal to 22 um, breaths per minute. This is easier to perform at bedside, but primarily designed to identify deterioration, not as a screening tool for sepsis, and has better specificity than SARS, but also sacrifices sensitivity. So we need to be mindful if we decide to use the Q sofa. Again, we can look at things like early warning scores, such as the Muse or the New score. This is widely adopted by hospitals. They use an ordinal scale based on vital signs and clinical presentations, and they are not specific for sepsis, but effective for detecting general clinical deterioration, including sepsis risk. And I think that if we're able to detect them early, we are able to mitigate how far they can go in terms of this. Again, one of the areas we need to look at is in addition to the early recognition, is the training of staff to recognize these signs, such as tachycardia, hypotension, and altered mental status, as mentioned earlier, and also investing in rapid diagnostic tests to identify these infections. I'll end here. Thank you very much for listening. And if anybody has any questions or contributions, you're welcome to join in the discussion.
We also have an example. Thank you, Emmanuel. We also have an example. These are paper screening tools that before in the United States and elsewhere, before we used computers, EHRs, we would fill this out at the beginning of each shift as part of our assessment for screening for severe sepsis. So it has the SIRS criteria that Emmanuel talked about laid out there. And if you don't have two or more of those, then you stop the screening. If you have two or more, then you ask the following question. Is there a suspected or documented infection? So is the patient already on antibiotics or is somebody suspecting it? If the answer is yes, then you move into the next one, which basically says in the last 24 hours, have any of these organ dysfunctions occurred. So, is my SAT reduced? Did I have that drop in blood pressure? Is my urine reduced? Do I have a lactate greater than 2? And if the answer is yes, then I screen positive for that dysregulated host. And if I'm in a med surg area, I'm calling my ICU people to come help, or I'm calling my doctor to come and start a protocol. And the protocol can be very simple. If you have the tools, you get blood cultures, you start antibiotics, and if they're hypotensive or the lactate is elevated, you give fluids. The treatment of sepsis early is very simple. And if we catch it early, we can keep people in the med surg area and we won't need those ICU beds. So this is a tool that is available on the Surviving Sepsis Campaign website. You can download it. And this is something you as nurses can work together to initiate this as part of your shift assessment. So something to think about. And let's do questions.
Thank you so much. So everyone can be free to unmute themselves and ask questions or ask questions in this chat if you want to.
Good evening. First of all, I would like to thank each and everyone for the great presentation. Just to introduce ourselves, Timothy John Ngausi. We are from the Far East University, Nicanorias Medical Foundation here in the Philippines. So this was a very, very nice presentation regarding sepsis. And actually, we are in our fourth year as nursing students. So sepsis is one of our topics in medical surgical nursing. So my question is more of towards this topic. I just want to clarify, for example, in the 1 hour bundle about sepsis management, I just have a question. Like, for example, if the lactate is in the level of 4, should we proceed with the crystalloid administration, or would we first check for blood culture? Because it actually was a difficult question or an examination, and we just want to be more knowledgeable regarding these interventions. Thank you.
So that is a good question. If somebody has a lactate greater than 4, I would be giving the fluids while I get the blood cultures. It's almost a simultaneous act. Somebody's on the arm getting the blood cultures, somebody's hanging the fluid, and as soon as the blood cultures are gotten, then you go get the antibiotics. Because that patient is in shock, the most recent sepsis guidelines, my understanding is the new version is likely coming out in February 2026. But in the previous guidelines, they said if the patient is in shock, which by the way, lactate greater than 4 puts them in that definition, then they should get the antibiotic within that first hour. If they're not in shock, then you have a little bit of time window to do some more diagnostics to identify if there is an infection and what is the likely source so that you can be more specific in your target of the antibiotics. Because we tend to give broad spectrum in the shock, and we're trying to get a little more specific in the non-shock, but the 3 hour because of antibiotic stewardship.
Thank
And
you so much for that answer.
I'm glad you guys are learning about sepsis in school. That's awesome. Other questions?
May I ask a question, Kathleen?
Sure.
I was really interested, as you said, well, I would call the doctor if I recognize someone breathing way too fast and having hypotonia. And what do you think we could improve in terms of communication interdisciplinary so that we have a faster recognition of sepsis? Because as you say, the doctor at the telephone didn't really get it, right? He
Yeah.
said, okay,
Yeah.
just give some fluid and then we go back to that. Like, how
Well,
can we do as a team? Yeah.
that's where that screening tool really helped because I'd use SBAR communication, the situation, the background, the assessment, and then the recommendation. And I would give the physiology, but then I would say they screen positive. And it would make it much more difficult for the physician not to pay attention to that
Yeah.
as a part of it. And then another piece that I utilize is in that S bar, if they're not paying attention, in other words, they're not getting what I'm trying to say, there is a short little phrase. It's called cuss. I am concerned. I am uncomfortable. This is not safe.
Mm, that's really good. I will take it home, take him home. Yeah. Okay.
And David made a comment. It's difficult. I work in some old hospitals in Uganda and Gambia, poor lighting. Clinical areas need to have good natural light. The other thing is if you're, most everybody has an iPhone or some type of phone these days, turn the flashlight on the phone and utilize that as your lighting. I know natural light would be much better, or fluorescent light, but if there's poor lighting in your facility, use the best you can. And that would probably be the flashlight on your phone as a part of it. We have a question here. What would be the suspicion for a patient whose lactate level cannot be measured, resource unavailable, but has all the other clinical? It's okay if you can't measure the lactate. If they have all the other clinical things, that also means their SAT's a challenge, their mental status a challenge. So you only need one organ to consider them in significant trouble. And this is not just a simple infection. And so if you're in a low resource area and you can't get a lactate, that's where you're looking at the skin and the modeling and those changes that take place. So another question that came across, I'd like to ask, are there cases where Q-SOFA or SERDs might be missed early in sepsis? How do we catch those? The way we caught them is through screening. Every shift, the beginning of every shift, because then the nurse is aware of those signs and symptoms. So if the patient shows them in the middle of the shift, your brain is going, oh, I checked this in the beginning, they didn't have it, and now this has changed. So that routinized screening, I can't tell you how important that is to capturing sepsis early.
And that
Those
is
are
something, sorry, Kathleen.
questions. No, those are great questions.
Yeah, and that's just something that could be easy to implement, right? We don't do it in a
Yes.
hospital in Berlin, but I guess that could be something
Yes.
that could be also be done during the transition, right? So not
Yep.
to forget to talk about the scores. Yeah.
It
Good point.
empowers the frontline nurse for that early recommendation. And we do it Q shift. And so if our shift is 8 hours, then it's done every 8 hours. Now the computer in the background will then send you alert and then you rescreen to determine it. The other on QSOFA, the data on QSOFA, and thank you for that question, is it really tells us. So the way I use it is I do that screen, I recognize the sepsis, and then I look and say, do they have two of those? Two out of the three. And if they do, I try to move them to the ICU because their risk of mortality is significantly higher. That's what QSOFA tells us, their risk of mortality.
Q-SOFA is also a parameter for to see the development of the sepsis. So you can
Yes,
see, okay, yeah,
but it's not, it doesn't tell you that they're in sepsis.
exactly.
Great questions. I don't see any more. You guys have been wonderful. Oh, Timothy, you got your hand up?
Yes. There's a question regarding sepsis as well. It's more of um other people. So since we are part of the healthcare team, how do we teach people who are not in the healthcare sector, like for example, our family members, to be able to check on their family members? Like for example, I have a cousin who is experiencing this particular infection, and then it most likely progressing to sepsis. But then, of course, since they're not part of the healthcare team, they don't have any idea. So what knowledge could we impart to them for them to be able to at least recognize that there is already an impending problem or healthcare problem to their members of the family?
So, Timothy, I'm going to direct you to the WHO and also the Global Sepsis Alliance, especially their toolkit for World Sepsis Day. It has an infographic specifically for educating families and regular layman people what you need to understand and when you need to go see a healthcare provider. So it talks about the fever. It talks about if your loved one isn't making sense, and I recognize grandma is mentally not the same that she was 8 hours earlier. So it has 4 or 5 different things to be able to teach family in layman's terms. So I go to the Global Sepsis Alliance. Thank you for putting that in the.
You're welcome.
When assessing for sepsis in patients with COPD, how can you distinguish septic tachypnea from baseline? I will tell you, Angel, it's challenging because their tachypnea, but their tachypnea may increase beyond what their baseline is. So you have to figure out what their baseline is and then determine how much above their baseline that they are. And that will tell you whether they're having tachypnea. Personal experience, family. We've had my brother-in-law, my grandnephew. So we've experienced it where we had to sort of coach. This is not a heart problem. This is a sepsis problem. And then they were able to successfully jump on it. So definitely have had personal experience with the sepsis management as well as being a clinician. We have somebody with their hand raised.
Yes, hello, Miss Kathleen. Am I audible?
Yep.
I have a question. So, how do we ensure that the blood cultures are obtained before starting antibiotics without delaying care?
How do you ensure that they get done?
Yes, without
Uh,
delaying care for our clients.
so it's something that you just you have to work out a process to where you have lab or the nurses are taught how to draw blood cultures so that multiple people are working simultaneously.
Oh, thank you.
That is got to do with the hypoglycemia bit, where we tend to focus so much on patients receiving fluids and inotropes and all those ones. But sometimes we tend to miss that these people do not have enough glucose, and therefore we need to be monitoring their glucose as well. And so we find them in either respiratory arrest or cardiac arrest, and somebody goes in to check the glucose and we have a hypoglycemia. At that stage, it becomes very difficult to revive these patients to level they were before. So yeah, that's an experience I'd like to share, that we need to keep an eye on their hypoglycemic state when we have sepsis patient in our care as well. Thank you.
Thank you, Emmanuel.
Thank you, everybody, so much. This was wonderful.
Thank you, Kathleen, for your time, for the all preparation, and for your insights. We've learned a lot from you and from your experience. So thank you so much, and have a nice flight. Anyone
Fantastic.
else has any questions to share? In the past, the capillary refill time has proved to be an early indicator of abnormal physiology that occurs in sepsis. Yeah, so capillary refill time is an early indicator, especially if you're in a setting where you have no way to measure blood pressure. Then that is one of the first indicator that goes the fastest. So it's still one of the indicators you can use. But now we have, if you have the possibility to measure blood pressure, of course, that would be something that is more accurate. But the capillary refill time is one of the first thing you can check, right? And you could actually use it as one point if you are doing the QSOFA and have no way to measure the blood pressure. Would you do this? Would you think the same, Emmanuel? Or do you have something to add to that?
I think that in my presentation, I didn't mention that some of the things we do should be specific to the settings you find yourself. And sometimes the only way you can do is by touching the patient to find out whether the patient is right, actually in shock. You want to find out temperature and other things, including the cap refill that you're talking about. So yes, we are actually not out of place. But if you have the luxury of all the magnificent tools, why not?
Exactly. And on our website, we could share, because it was asked in the chat, some checklist for sepsis at the ICU you could use for your transition, your shift transition. We could put that on our website, right? So you will get access to that. Okay. Some other question from the chat. Yeah, from Derek. Are there any new data in anticipating a patient's risk of progressing from SIRS to sepsis or severe sepsis? Do you mean like how to anticipate? Well, how to anticipate, like there are a lot of data. How to anticipate to go from a sepsis to a septic shock is to reassess your patient. Yeah, so you reassess your patient a lot of time so you can recognize, okay, this patient is in shock or not. Because if your patient is in shock, you have to use this 1 hour bundle of sepsis, right? You have to give fluids, you have to do your blood culture and start with antibiotics within the first hour. And there are a lot of studies showing that if you pass this moment, the mortality increased exponentially. Okay. So we have a question from John. I would like to ask on a situation where fluids resuscitation is contraindicated with sepsis, such as someone having a heart failure comorbidity while having sepsis, understanding that the patient cannot take too much fluid as the heart cannot take it. What or how would we manage that particular patient? Okay. Manuel, do you want to respond on that or should I give a comment?
So I think that the general principle here is that in sepsis with high fluid sensitivity, so we're talking about heart failure, ESRD, pulmonary hypertension, you still need to address hypoperfusion quickly. But fluid volume rate and monitoring must be individualized, so not for every patient. And the goal is to shift from you giving more like a 30 ml per kilogram to everyone to give enough to optimize perfusion without precipitating fluid overload. So that's what I have to say about this.
Yeah, perfect. Exactly. So for the first hour of resuscitation with fluids, you have to give fluids, right? But
Yeah.
then you have to reassess and see if your patient need that fluid. So for example, you could also give only 250 milliliter of fluids and see if the patient reacts, right? If the patient is less tachycardic, if the patient has an increased blood pressure, that would mean, okay, this patient is reacting to your fluid bolus. And if not, it means your patient had a heart failure or is in shock. So you would rather not give too much volume.
Yeah, so I mean, the other thing you might also consider is the early use of vasopressors, and then some adjunct measures such as giving oxygen, diuretics, inotropes, and most importantly, monitoring. So urine output, lactate clearance, dynamic preload in these indices, and then of course, if you can, you might want to be adding daily weight and then cumulative fluid balance as well, just to make sure that your patient is in good shape.
Exactly. Thank you so much. Perfect. So we have a commentary from David. Passive leg raising is a good test if the patient needs IV fluid. I realize it's contraindicated in many situations. Yes, so it is contraindicated in some situations. Do you have an idea in which? So, for example, for patient with traumatic brain injury, you wouldn't do a leg raise test, right? For patient who has a lung edema, you would rather not do leg raise tests. You want to keep them with a 30 grades up, 30% up. But for a short leg raise test, and depend on the patient, you have to reevaluate it, but it could be indicated if you have no other tools to measure, right? So you could have, if you have access to ultrasound, you can do an ultrasound of the heart. If you have access to the blood, like to the arterial blood pressure, you could see the PPV, the pulse pressure variation. But if you don't have these tools, right, the leg raise test is an easy tool next to the capillary refill time. Okay. Emmanuel, something to add?
So again, uh, I think that you've mentioned most of the things. That what we need to understand and appreciate here is that passive leg raising is great. It's reversible self-fluid challenge, but again, as mentioned, it's not for every patient. So we need to be sure how we go about using that one. And as you mentioned, patients with spinal or pelvic injury, it may be contraindicated, would be at risk of worsening instability or dislodging clots and hematoma. So we need to be sure. We need to be um, patient specific and mindful if that's what we want to use.
And if you have questions, you are always there with a team, so please ask your team. That's the most important thing, right? Before doing things you're not sure of. Okay. Some other questions? Um, okay, I guess we are done. If you have more questions, feel free to ask. We let you our contacts on the email, the registration email. So you are free to ask any questions. And yeah, thank you so much for being here. There are a lot of people asking for e-certificates. So we haven't done some e-certificates yet. And as I know that now there's a big demand, we will come back to you and I will talk to my colleagues so that we can organize that. Good. I don't know if Kathleen is still here, but I would like to thank Kathleen for her time and of course Emmanuel for your time and for your insights and answering all that question. Thank you so much and have a nice evening. And this lecture will be recorded and put online in the next weeks.